or somebody hit the
Oh, is that
record.
up to me? Up,
I
yeah,
just
we
did.
got it.
Thanks.
Got it. Thank you. We
Sorry.
always seem to forget that uh there, but yeah, no, it's a special day today. Again, I want to review some of the things we've gone through before, both for the benefit of our guests as well as for repetition. So we'll just kind of strap in here. Let me share screen there. Hope you're seeing that. Got it? All right. Here we go. And again, thanks for your time and interrupting your lunch and your busy days with this valuable information. As you heard, this is being recorded. So if you or your colleagues want to see it again or you missed it, you're able to do that. So as we usually do in these forums, we give you educational tips for success in the ACO. Again, you're part of the clinical network, but you're also part of our accountable care Medicare shared savings program. These are your practices, which you are well aware of. These are your representatives on the oversight board for the ACO. The committees we utilize for the ACO are the same committees in the PA Clinical Network. Anybody interested in any particular committee or just participating in is helpful because we are self-governed. This is not top-down. The input and your suggestions are what we implement. As you know, we just recently last month submitted the quality reports. You can see 2023 is a little bit better than 2022 in many categories. The yellow highlights are going to be the focuses for 2024 and reporting. The quality care Medicare is shifting from the 10 web measures. And as you know, the blue highlights were collected but not scored. So your actual result didn't really matter. But the blood pressure, A1C, and depression are going to be the big foci going forward this year. We talk always that coding comes down to how CMS sees us and scores us. So even the best care sometimes is not reflected if it's not coded properly. And as always, we try to give you the data insights to work smarter and not harder. And our guests will talk about that a little bit too, going forward. One of the first things we shared was actually your performance. Each of these dots represents one of the practices. Your financial performance, as well as considering the risk of your population. Again, this shifts throughout the year. So this was at the end of 2023. We've been working with you, and we do expect the dots to shift further. Obviously, we want to get everybody green, and we want to get everybody over that 5% line there. One of the last topics we had last time was missing codes. So then in 2023, we had about almost 4,000 codes that we did not see back. We did not see in 2023 that we saw in 2022. That was about 25% of the codes. Most of those were codes that were previously recorded outside of our network, so that your specialists or your consultants had that in outpatient arrangements. And many of the codes are suggested that they are chronic conditions. Vascular disease, CHF, and rheumatoid arthritis certainly are things that don't typically disappear, so that even if your consultant is managing it and you know that patient's under consulting care, you too could and should document those. Acute renal failure may or may not persist, but typically there's some element of residual renal impact that you may be able to code. One of our other topics was churn and how that can be detrimental to a population in your practice. And basically, high churn means that your good care is being lost to another ACO, and they're getting credit for the good work that you're doing. Most of the time, it's due to plurality, meaning the number of visits. So that if you have one visit and another doc has 8 visits, that doc may assume the care of that patient unless you have documented properly and followed them up. Annual wellness visits are a good way to actually recapture and minimize churn. And this is a list, at least by practice, of how well you're doing in your annual wellness reports. And this shows the same common denominator, that no matter what the size of your practice, The last 5 to 10% of the patients in that practice determine your overall performance and also determine the performance of the overall network. So that sharp right shoulder makes all the difference in the world, how sharp it is and how deep it goes, in terms of cost implications. We've come down to the big five, basically, the points that you should be always striving for in your practice, with annual wellness visits, chronic care management, advanced care planning, behavioral health, and transitional care. And we're going to focus on the 5% there, the impactable utilization, accurate coding, and the high priority patients. It sounds all confusing. Possibly it is. We've said a lot. And again, as a new ACO, we're learning a lot, but it always comes down to the same basic. These are your practices are great practices. We see good care throughout the network. And basically, as long as you keep doing the good care you're doing, we're going to do great and we're going to be very successful in this. So again, we'll give you the tools and the patients to focus on, and the bottom line is you do your complete care of the patient, capture that whole patient, including the conditions that the other doctors are caring for, and of course code accurately so that you get credit for it. In the coding, we talked about, as long as you're monitoring, treating, assessing, or evaluating, even referring, that is fair game for your coding. And the other acronym, tamper, which is a little bit more exhausted in that. But again, even codes, and that's what we're seeing in the HCCs, even diagnoses that you're not directly treating, you can do that. So it's the 3 C's: care center collaborative, which was our original name, but also complete care for your patient, capture the whole patient, and code correctly. Other topics we touched on is the laboratory services are an expense point, and a lot of the hospitals in our system are using a lot of lab services. That is 3 to 5 times the cost that you may be able to get an equivalent LabCorp or Quest. Keep that in mind as you're ordering. LabCorp is working with us to have a direct feed into your EMR so you could get the results quickly in there without undue burden. And also, there's a lot of convenient locations that may service your patients better in the end. One last thing we touched on, but we're seeing more, and we will be reporting this to CMS. You may have heard about a DME fraud that took place last year. It has to do with urinary catheters. There are 2 codes that popped out of the blue in 2023. CMS, as well as NACOS, the National Association of ACOs, highlighted that to us. We did take a look at our own data, and indeed, it looks like we were the subject of fraud. So we will be giving to you the list of your patients that we think fraudulent activity has occurred on. It's to the tune of almost $2 million there. In 2022, we had about $100,000. And so far in 2024, a little less than $100,000. 2023 stands out like a thumb in there. And there'll be more to come on that. But just to let you know, and why this is so important is because we, as an early ACO, are so close to achieving shared savings. This actually will easily tip us over the top if indeed CMS gives us credit for this fraudulent cost that should not be set on us. Again, we want to work smarter, not harder. One of the new announcements, and you may have seen it in the news this week, is our new collaboration and partnership with Guide Health. Guide Health is going to enhance all of the things that we're doing for your practice and all of the things that you're doing already, and it's going to extend the reach of your practice at no cost to your patients and at no cost to your practice there. And the missing ingredient, the biggest missing ingredient that they provide, and it is a robust partnership, is extension to the patients. We support you and we support what you do for the patients. Guide Health, as a seamless extension of your office, will, in collaboration with you, be able to reach out to those patients, especially the 5%, especially those that haven't been in the office, especially those that need touch points between office visits and before office visits in terms of reminders. And with that, I have the pleasure of introducing our guest today, uh, Dr. Sanjay Dodamani and Dr. Mark Selna of Guide Health to spend a little time talking about Guide Health and the new partnership. And we've left time at the end for Q&A as well. But with that, Sanjay and Mark, I'll let you introduce yourselves, and I'll also stop sharing. Mark, I understand you're going to share your own, correct?
That's correct. Yep. Thank you.
All right. And again, excuse my allergic voice here, but at least you're done listening to me for now.
Thank you, John, and good afternoon, everybody. It's really great to be on. I'm Sanjay Dadamani. I'm a physician cardiologist, and for the last 2 decades have been focused on improving performance and outcomes for provider organizations. I've had 2 tours of duty in Pennsylvania, first during my cardiology fellowship in Philadelphia in 2001 through 2004, and then back for almost 8 years, coming back in 2012 to work at Geisinger, where I led their accountable care organization, as well as drove strategy in home-based medical care. So I'm going to turn to Mark. He's going to do the bulk of the presenting, but just the vision that we've set out here that could help support you is to really be an extension to get to those patients that are difficult to coordinate with, to help to support be this extension, and to do this with a very advanced level of data science without and augment your performance. And that's a home run for us. So with that, let me turn to Mark.
Thank you, Sanjay, and thank you, Dr. Pagan, for the introduction. This is the first time we're meeting you, so we're going to try to not cover too much because there's some key takeaway points, notably that Sanjay and I, as physicians, Sanjay as a cardiologist, myself as a primary care physician, we've been in the industry for a long, long time, both as providers and as individuals who have developed population health programs, analytic tools, various AI-enabled capabilities, but have continued to see the need to support independent practices and health systems in providing better care in a way that makes healthcare more affordable and available to patients and more joyful and profitable for physicians, understanding that financial sustainability all around in the system is a huge, huge challenge. We having trouble advancing the slide. There we go. A couple highlights about the company. Parts of our company have been around for 25 years. We currently have 11 clients. We support 270,000 lives across multiple health systems. A lot of those lives are Medicare lives, and some of those are the under age 65, what are called commercial lives. Our company has received numerous accolades along the way for our customer service and our operations, and we have 200 employees who help us do that. As Sanjay said, and Dr. Pagan alluded to, a part of what we do is really leverage technology so that what we do is low cost, easy to extend to even the smallest of practices, and can add to the precision of identifying patients that would really benefit from the services that we do through your practice. We use both analytic tools and we use what are called health guides. Those are individuals who are medical assistant level trained, who are a part of your practice, not under a Guide Health name, not under a PACN name, but under the name of your practice, who are able to engage with your high risk or high impact patients, the 5% that John was talking about, so that they can get better clinical results, and so that the PACN in your practice can get better financial results and generate greater shared savings, so that ultimately you have a new revenue, an additional revenue stream, and can make your practice more financially sustainable, all the while without increasing the administrative burden for your practice. We as Guide Health do several things for the practices. I'll just go around the wheel there, starting at quality and care gaps. It looks like There is still a little bit of opportunity with PACN with the practices. That'll vary by practice. It'll vary by measure. And there are lots of workflow capabilities that we bring to better identify the patients who have those coding gaps, the recapture gaps that John talked about there before, not there this year. And there's also what are called suspected codes as well. Codes that based upon other clinical data, lab data, other documentation suggests that a diagnosis is present, but for whatever reason has not ended up in a claim. So there's both coding gaps, accurate code capture, and there's quality gaps. From a workflow perspective, we treat those all the same, but both of them enhance the quality of care, the ability to inform care plans by having better, more accurate diagnostic data, and then ultimately the shared savings. For those patients that are at highest risk, you can see that we do longitudinal care management. We also do episodic care management. Episodic care management is for those patients who may not have significant chronic diseases, but who, for whatever reason, have ended up in the emergency room with some acute problem, or were hospitalized and need to be transitioned and are at high risk of readmission. We want to prevent that. Longitudinal care management is for those patients who have known predictable high risk and high predicted risk of being hospitalized or ending up in the emergency room. We have lots of methodologies for doing that that complement what is done by you already today. And then at the bottom there are services that we do for some clients where they, from a private health plan, a Medicare Advantage health plan, might also have what's called delegated utilization management, not the case with PACN. We stratify these patients into those that require high touch. Those are typically the folks either on a short-term basis for episodic care or a long-term basis where it's longitudinal care management, or simply those that need light touch. Typically that's for care gap closure or for coding gap closure, or just sometimes behavioral health navigation. And then there are those broadly across the system that need coding or care gap closure. You can see it breaks down roughly 10 to 15% in the top there, 20 to 30% for the light touch, and then the remainder of the population for coding and gap closure. What's really important from a workflow perspective, these next two slides show workflow first for quality and coding gap closure, and the next one for care management, is that we do everything possible to decrease, or certainly not increase, the administrative burden on the practice. So these health guides, who are supported by nurses and social worker and medical director support through Guide Health, these health guides are virtual. They're not physically on site at your practice, but they are an extension of your practice. So they represent themselves as an extension of your practice. They are able to access patients through your phone number and through the name of your practice, and they document in your clinical record so that you have full awareness and transparency of everything that's going on, and so that you can sign off on and revise care plans, and so that any associated workflow optimization or analytics that's native to your EHR, you'll be able to take advantage of. And then lastly, though it's not a part of our initial rollout, is the ability for them to provide services on your behalf, as a part of your practice on your license, to enable billable services that you bill for. So that's an additional way to enhance revenue. It's not something that we're doing immediately out of the gate with the PACN practices. We're very much focused on the things that will deliver you value against your value-based care agreements. As John said, you were very close to achieving that threshold, and we want to ensure that that threshold is met. And then we'll build on that. This workflow example shows that everything below that middle line, that middle horizontal line, is the work done by the health guides and their supervising RN with your patients on your behalf. And for quality gap closures, it's using the data that we get from CMS, from the government, as well as some of the EHR data, to identify where there are these coding gaps, both the recapture opportunities and what are called the suspect codes. We identify where those are. We generate lists by practice. We work with you to identify how best you would like those handled. There's lots of different ways, but there's generally some of those can be satisfied just in the case of quality gaps with lab tests that can be scheduled by the health guide on your behalf. Sometimes it is an encounter, but we prep the chart ahead of time for coding to make sure that when those patients are seen by you, the things that do require attention are already brought to your attention, and can make sure that that is prepped so that it's easy to evaluate and easy to endorse, and so it's easy to drop and get into a claim. And then if there's any follow-up needed after those visits, primarily for purposes of quality gap closure, we would of course make sure that those get scheduled. This is also a workflow slide, but it's a different use case. This is for those high impact patients, those top 5%. And you can see here, we try to keep everything below the line, which is the work done by the health guides and their supervising RN on your behalf, so that the administrative cost and burden for you is decreased, not increased. As you know, a lot of these patients take up a lot of time in the practice, and they not always with revenue generating activities. So we like to make sure that the relationship that these health guides develop with your high-risk patients are ones that is a very trusted relationship, and one where those patients can rely on that health guide to meet a lot of their needs. So they're bothering your practice less, and making sure that care that you need to provide and oversee is escalated at the right time with the right amount of prep so that you can be highly efficient. In this case, we're talking about a patient with heart failure. Initially, after the health guide develops a relationship with you and your practice so that you're comfortable with who that individual is and what their skill set is and how they're going to be outreaching to your patients on your behalf using your endorsement, your practice name, and your phone number, that you're very confident and comfortable that that process is one that meets your standards, and that health guide, having been introduced, has a much higher likelihood of developing a strong actually engaging with the patient. Lots of third parties, as you probably know, who reach out on behalf of health plans, independent of you and your practice, are not warmly or well received by patients generally. This model, what we do, fundamentally addresses that from the get-go. They are an extension of your practice, not of PACN, not of the health plan, of a health plan, not of CMS. So once they reach out, they develop that trusted relationship over several sessions. They're able to identify all of the risk factors or health determinants that contribute to that patient having preventable future emergency room visits and hospitalizations. And they're able to put together a draft care plan that is then made available to the practice for your review and revision. And once in place, it is discussed with the patient so that they know this care plan is meant to be a holistic, comprehensive care plan, that it covers what you as the primary care physician would want, or what the specialist, the co-treating specialist would want as well. If according to that care plan, the patients need to escalate, if the existing clinical protocols that are embedded in those care plans and endorsed by by the practice physician, if those protocols do not take care of the exacerbations that your patients might experience that otherwise would result in an emergency room visit, then there's escalation to you to make sure that everybody's on the same page and we know what to do to, again, try to prevent that escalation from going any further and to mitigate it. And always try to direct the patient based upon your preferences to the setting that makes the most sense given what the clinical need is for that patient. Above the line is just those occasional interactions initially when we start these programs, making sure that the clinical protocols are ones that make sense so that once they get embedded in care plans, they work. And then once in care plans would be a review of the care plan to endorse it, and then with any escalation to make sure that you, the practice, are comfortable with the escalation procedure and what's going to happen with that patient. And then once that escalation is dealt with and that care plan ultimately is revised, then any follow-up visits or laboratory tests or changes to that care plan are done by the health guide and the RN in your record. So again, there is some redundant documentation that we do in our system so that we can do deeper analytics, but we always make sure that the documentation is in your clinical record so that you never have to wonder or worry about things that are being said or done for your patients that are not in your record. I'm gonna stop there and ask for questions. Both Dr. Dadamani and I would be glad to take your questions, or Sanjay, if you wanted to add to what I said before we take questions.
Look forward to hearing the questions. Maybe
Yeah,
we
and
can take
I'll just while we're waiting for questions, and you can put them in your chat, or you can raise a hand there. And if you think of questions after today, certainly feel free to forward them on. But again, I mean, there's at the most basic level, we're very, very excited about Guide Health because philosophically they are aligned with us and independent practice and our success. That of course we wouldn't consider them any other way, but again, the fundamental alignment is to help us and to help you. And in that, you know, whatever is working for your practice, this is not intended to replace or disrupt that. This is, again, an enhancement, a supplement, and it allows us as a PA clinical network to not only reach out to you and give you helpful tips and actionable information from the data, but now has the opportunity to reach your patients and help you reach your patients, given your almost overwhelming and sometimes very, very busy schedules and office staffs that don't have capacity for a lot more. So this is the Guide Health relationship is to enhance and extend all the good things we already have, not to disrupt and not to replace. So just to emphasize that going forward.
Yeah, a key design principle that we started with and we continue with is we augment what you already have. We don't replace, we don't compete, we augment. And then we also seek to unburden. So from an administrative standpoint, we want to make the life of the practices better and easier, not harder and more confusing. As a former practicing primary care physician who ran my practice, ran lots of clinics, multi-specialty, the day in the life of a physician is very, very challenging. And there's lots of work that gets put on physicians that frankly we weren't trained for, nor would I even consider it physician work. So we really want to unburden the physician and unburden the practice. And two, we don't want to compete with anything that's there and working.
So each of your practices on an individual basis will be introduced to Guide Health, and they'll learn about your practice and you'll learn about them. We talked before about certain practices that, you know, we're going to do this in phases. We can't do it all at once. And certainly as we learn each other, it'll be most effective to do that. Some of the practices have already raised their hand and said, hey, we'd like to try first. We'd like to be part of it. Some of the practices, looking at our overall data, we noted can be very impactful for the whole network. So we'll be reaching out to them earlier rather than later as well.
The questions that have come through the chat, I'm wondering.
Yeah, Dr. Pergolini, one of our board members, asked a great question in terms of the top 5% patients or targeted patients. As you know, we've calculated some of those patients on our own. It'd be very interesting to see how that mirrors Guide Health. But Mark or Sanjay, how will you be determining the target 5%?
Let me take a crack at answering just the first part of this. Is earlier this year, under the rubric of a business associate agreement and NDA, we were able to ingest some of the publicly available data on the Medicare lives to determine risk and determine performance. And so with that, we have some internal technology infrastructure that has allowed us to use advanced machine learning algorithms to determine risk exposure, reversibility of trend, and what that risk stratification looks like. So that's where we develop the first 5, the next 5, and so on. The other thing is how we then put it into practice, and I'll turn to Mark to describe then what do we do about it, because one is the knowledge sharing and the understanding from a data science aspect. The other is how can we collaborate with you to help improve access and coordination of care for these patients under that rubric. And then finally, today you have an existing Medicare shared savings program under the PACN arrangement. That's where we have started our collaboration. Mark?
I would only add to that from the data that we received, we've been able to determine where the greatest opportunity is in medical expense savings. Some people call it total medical expense. Some people call it total cost of care. In addition to that is where the greatest opportunities are in terms of coding. And those two don't always line up. In some practices, some physicians, the opportunity is pretty significant for both, and sometimes it's one versus the other. And then lastly is quality. So we're looking at a combination of all 3 of those opportunities to see where we can really hit the ground running. And then, of course, as John already said, there's always the coalition of the willing. So those practices that are most interested in doing this kind of work together, obviously it's a lot more fun and enjoyable and in the near term effective for us to be working with the practices that really want to do it. So it's both based upon opportunity and willingness and excitement to engage in this kind of work. And it is, as Sanjay said, this is just for Medicare, straight Medicare today. With some of the other organizations that we work with, where we help them with a much larger percentage of their practice by helping them with multiple payer contracts. So it's different models in different places. Anne was asking, how is this service paid for? John, I don't know if you want to answer that or if you want me to.
I'll start with that. And again, that comes from Dr. Gambosi's office there, and a great question. And this speaks to the philosophical alignment and actually and it speaks to you and us as a network that we caught the attention of Dr. Donamani and Mark and this company, which again, although they have old components, they're a new company and a new concept. And they're looking to prove that concept, and they see in the PA Clinical Network an opportunity to do that. We were able to arrange with them where they will participate in the new levels of shared savings. They'll get a percentage of that. The existing level of shared savings, which we're already achieving on our own, is the first layer that we keep for ourselves. Above that, as Guide Health helps us achieve higher levels of success and higher levels of performance, is where Guide Health will get a portion of the savings that we will also do it. So they are invested in our mutual success. If we do not save any more than we're already saving, if we don't save any money at all, Guide Health doesn't get a dime. But they're so confident in their model and in their structure, and they're so eager to prove it to not only us and the world, that they partnered with us to do that. The other thing that's exciting is that this gives us, as a medical society sponsored entity that has a statewide clinical network, an opportunity to show other states how it can be done. So I'm very excited in the partnership too, because it introduces to us a possibility for scalability and seeing this model now roll out over the country. I hope that helped at least answer that. So again, that's why there's no cost to you as a practice, and there's no copay or cost to your patient in this.
John, if I can just add one line to that philosophical alignment. I fundamentally believe that first dollar savings should go to physicians. And so we have put ourselves at risk in knowing that the way we collaborate will be welcomed by you, the practices, that will welcome incremental performance, which is the only way we will ever get paid, is for that incremental performance.
Great.
Thank you. I want to respond to Dr. Piergalini's last question. What if the practice identifies a patient that may benefit from this, but not in the 5%? If it's a patient who is Medicare and our algorithms didn't pick them up, but this is somewhere where you go, Yeah, my clinical intuition, my years of experience, I know that this is a patient who's headed in the wrong direction. And if we don't bring the guide health type of services in, it's definitely going to end up getting hospitalized. We absolutely will add them to the roster. We will absolutely add them. So, the algorithms are only based upon the data it can access. And so if it's not in the record, or if it's not easily discernible from the record, and or the algorithms don't have a good marker for that, they're going to miss it. So we would absolutely defer to the expertise of the physician in the practice regarding which patients you think are particularly high risk, but for whatever reason are not on the list.
There are two guiding principles we have. One is stood up by AI, and the other is by empathy. And to me, even if you have a complex cardiac patient with a rural distance to a tertiary facility and needs some transitional extra support because they're diabetic and they've just had open heart surgery, they would never have been picked up on a machine learning algorithm list. We would absolutely support ensuring that we're coordinating care in their post-transition environment. So just that human factor is very central to our understanding and on the basis for our collaboration.
Yeah, I think that's a great point. Always, if you have input, and again, your patients better than anybody, your community better than anybody, and accurately and effectively deploying that is essential to have your guidance. And the other thing that I'll say, and I'll just leave it open because we're working through the rollout right now, and which practices and things like that. The 5% can shift during the year. So we may first focus on 5% patients that have very high utilization, but don't have associated risks or diagnoses to explain why they're using the system so much. That may be the first 5%. We may, as the year go on, we may go to the 5% of patients that should be seen by you, but have not been seen in the last year or so, and are on that verge of attribution or churn that may be key. Again, I think the same common denominator, which Guide Health will help extend, is just taking good care of the patient. We will try to give you the smart information of which patients we see as important and impactful for your practice. And it may vary from practice to practice, but we'll give you a manageable number of patients that, hey, these are the ones to focus on. Do your good care, completely capture the whole patient, code them accurately. That's the same thing, every patient, but the list of targets may shift a little bit as we get better and we've taken care of basic problems. We may look for others where we can make an impact in doing that.
Of the 7 or 8 practices represented here, I'm hoping that you will reach out to PACN team to offer to be early adopters for us to be able to work out all of the things that you would want to see happening for supporting your practices and adding resources to the practices. So I hope and appreciate your time today, but I really hope that it also follows on to us getting an early start to working with one another. The last thing that we did not highlight during the presentation today is our market search for the best available point solutions in technology. Some of them are AI, some of them are some automation, and we've really gone out to go and find these and pay these vendors and bring them onto the platform so that we can use some of those resources to the benefits of the practices, the providers, the patients, whether it's advanced risk stratification, whether it's some automation for patient surveys. Just think of a fall risk assessment or PHQ-2, and then to get that information into your medical records so that it impacts quality, it impacts mitigation of risk, and it impacts improvement in care and coordination of care.
I just want to address, looks like what might be the last question in the chat there. How do we introduce this to our patients? A very core part of what we do is to make sure that we become a trusted part of that relationship with your patients, but we go through a trusted relationship. So it will vary according to the patient. It'll vary according to the practice, how we do that, but it will be an introduction by the practice to the patient. Again, we're going to figure out those patients who are the highest priority from the beginning. And we're not going to seek to engage every single one of them on day one. We're going to be very deliberate about it. And we're going to introduce them, the health guides, through the practice, ideally through somebody that your patients already know. This is not an expectation the physicians who would be calling them, but it would certainly be an introduction through the practice. In some cases, it may just simply be introducing through your phone number if we think the patient would be amenable to that, and your staff will likely know better than us, versus having one of your staff members actually do the introduction. So it'll vary according to the patient, but it'll be it'll be an introduction of somebody new to the practice, a new staff member who is there to help that patient achieve certain things. And so it'll be with the strong endorsement of the physician that will happen.
And we're getting close to the hour. Welcome additional questions. Again, you will be hearing from Guide Health and us as we introduce it going forward. Anybody interested in being part of that sooner rather than later, let us know. We also have some preliminary ideas which practices will help benefit the most with a little bit of extra help. And remember, this is all born from actually your conversations and the oversight board and the committees who have noted that although we're new as an ACO and we're so darn close to hitting shared savings, we needed to do something more. We needed to do something different to make sure we start going now to the higher levels. We've already proven good care. We're already proving savings to the Medicare system. We just need to take it to the next level to participate. And a key part of that is the patient outreach and being able to help you reach out to your patients more than your busy schedules already allow. Again, a reminder, through the PACN website and your portal, you can access a lot of the review material that I've presented before. You'll be able to access this recording if you wanted to go over it again. Also, your individual performance, which dot you are on the graph, and other helpful tips from our quality team are also on that website. Keith and Wendy, anything in conclusion that we should have hit on?
Nothing from me.
Nope,
Yeah.
I don't believe so.
Great.
Well, thank
All
you
right.
for having us.
Again, looking forward to an exciting collaboration and again, taking us to the next level. Appreciate all of your time today. Again, more to come and you'll hear from us. Have a great afternoon.
Everybody.